Good afternoon, everyone. I thank the chairpersons for the introduction. It's really an honor to be here today. Today we'll discuss tissue markers in breast cancer patients undergoing neoadjuvant chemotherapy. I will start with general overview. Our objectives today about the importance of tissue markers in breast cancer, review the common types of markers, either surgical clips versus ultrasound visualized tissue markers, and share our institutional experience and published results. This workflow showed that the typical sequence of management, we always start with diagnosis by imaging and biopsy, then the marker is inserted either surgical or tissue marker before starting the neoadjuvant chemotherapy. After treatment, we use follow-up imaging to assess the response and check the marker visibility. And finally, these information guide us for the best surgical planning. Breast cancer is the most frequent neoplasia in women. The increase in breast cancer incidence is accompanied by an increase in the clinician and the researchers' concern regarding the improvement of diagnostic and therapeutic tools. Neoadjuvant treatment represents an increasingly common approach for patients, and starting with chemotherapy in breast cancer patients proved to be cause of decreased incidence of recurrence and breast cancer mortality rates. However, post-neoadjuvant surgical management may be complex, as the neoplastic lesions can show total radiological response. However, the total radiological response not always equals the pathological complete response. In radiological complete response, the lesions might have dramatically shrunk to the point not being visible on ultrasound. Well-visible breast tissue markers need to be placed in these lesions in order to enable better surgical options and outcomes. Breast cancer are heterogeneous, showing variable morphologic and biological features, and thus different clinical behavior and response to the treatment. Cancer classifications aim to provide an accurate diagnosis of the disease and prediction of the tumor behavior to facilitate oncologic decision-making. According to histological classifications, most of the breast cancer are classified as infiltrating ductal carcinoma of non-specific type, indicating that histologic typing represents a broad categorization rather than detailed classifications. Regarding the genetic expression, we categorize breast cancer into luminal subtypes with characterizing estrogen receptor expression. As seen here, they are arranged in clockwise direction in relation to the prognosis from the best to the worst: luminal A, luminal B, HER2 positive and triple negative. The luminal A has the best prognosis with expressing ER and BR with negative HER2. Luminal B with poorer prognosis, weak ER and weak BR, either positive or negative HER2. HER2 positive with negative ER and BR with also poor prognosis, and the triple negative hormonal profile with the worst prognosis among them. According to RECIST criteria, either complete response with complete resolution of the lesion, or partial response with 30% decrease in the size of the lesion, stable disease, no interval changes, and progressive disease with 20% increase of the lesion or newly developed lesions. The key challenge is that the tumor may shrink or even disappear after the neoadjuvant chemotherapy, making the localization is difficult. So we use the most common types of clips, either surgical or tissue marker, for better surgical planning and tumor bed detection. We start with a surgical clip. It's simply made of pieces of titanium and cheap and widely available. We bring it in cartilage like this and open the clip and handle by sterile holder, bend it manually, introduce it to the lesion via angiocast. The other type is tissue marker and usually has surrounding material, either collagen or polylactic acid, polyglycolic or hydrogel, applied simply by just firing a button while retracting the needle. This is a short video about the application of the tissue marker. Now we move to some of complications of the clips. First, pain or discomfort, mild pain at the insertion site and usually self-limiting. Infection can occur if aseptic technique not optimal, like this. hematoma, small bleeding under the skin after the insertion, migration of the clip, either intralesional migration, the clip move inside the tumor, like this picture of ultrasound. First, it was in the center of the lesion, then on her follow-up, we detected at the periphery. The extralesional migration of the clip, we applied it in the lesion, then we found it away from the tumor. Once we know this possible complication, we can avoid it by careful ultrasound-guided insertion, aseptic techniques by using betadine and sterile gloves, gentle compression after the procedure, and follow-up imaging either by ultrasound or mammogram to confirm the location of the clip. Now let's move on from the theory to our practice. I'll share our institutional experience. We conducted a comparative cross-sectional study on breast cancer patients prepared for neoadjuvant chemotherapy using surgical clips and tissue markers. Both types were inserted under ultrasound guidance, and after the neoadjuvant therapy, the clipped masses were compared by ultrasound, and in case of non-visualization, further mammogram were done. Our results showed that clip visualization was satisfactory in both groups, showing no significant difference between the surgical clip group versus tumor marker clips as visualized by ultrasound, with p-value less than 0.5. We found also in our studies there was no significant relation between the effect of types of response of tumor after neoadjuvant chemotherapy with clip visualization after the treatment in each type separately, as well as no significant relation with different response with visualization of both clips. Regarding the complication, pain wasn't significantly different in surgical clips group versus tumor markers, as well as the other complications such as infection, hematoma, and migration. Some cases of our research. Case number 1 was a 42-year-old lady with right breast cancer. Pathology was infiltrating ductal carcinoma with ER, BR negative, and HER2 positive. The first picture showed surgical clip in the center of the lesion before the treatment. And second picture reveals the regression by 50% of the size, still the clip seen by ultrasound. Second case was a 40-year-old lady with left breast cancer. The pathology was infiltrating ductal carcinoma with triple negative hormonal profile. The first picture showed ultrasound-guided tissue marker was inserted in the center of the lesion. And second picture showed regressive course of the lesion with intralesional migration of the clip to the periphery of the lesion. Case number 3 was a 47-year-old lady with right breast cancer, infiltrating ductal carcinoma with ER and BR positive and HER2 negative. First picture shows the surgical clip in the center of the lesion with mild hematoma at the periphery. Then in her follow-up after 6 cycles of chemotherapy, the clip is still seen by ultrasound with resolution of the hematoma. Case number 4 was a 34-year-old lady with right breast cancer. The pathology was infiltrating ductal carcinoma with triple positive hormonal profile. Ultrasound-guided tissue marker was inserted in the lesion before the treatment. After finishing her chemotherapy, we couldn't detect neither the clip or the lesion by ultrasound, so we did complementary mammogram revealing the marker in the site. Our last case is a 51-year-old lady with left breast cancer. Pathology was infiltrating ductal carcinoma, ER and BR positive and HER2 negative. First picture showed ultrasound-guided surgical clip was inserted in the center of the lesion. Then after finishing her chemotherapy, near total resolution of the lesion, still the clip seen inside by ultrasound. This finding I have just presented were peer-reviewed and published in the Egyptian Journal of Radiology and Nuclear Medicine, which validates the importance of our work. I would thank Dr. Shireen George and Dr. Asma for their supervision and support to all the theory. To conclude, our data showed that the visualization of both surgical clips and tumor marker clips on the ultrasound before and after neoadjuvant chemotherapy were nearly equivalent, regardless of the lesion prognosis and the complete radiological response. Using radio-dense marker clips to designate the region of interest is reliable and efficient technique as the surgical clip is cheap and widely available. It's important to determine the types of breast tissue markers that exhibit greater visibility on particular imaging modalities. Complications of clips such as pain, infection, hematoma, and intralesional, extralesional migration were comparable in both groups. Our recommendation is ultrasound localization by targeting clips may not be beneficial in many patients. Another imaging modality such as mammogram will be necessary for clip localization in those patients. Additional trials aid in decreasing the cost of material used in tissue marker. Thank you.
Thank you very much, Dr. Sommer, for your very informative presentation, and actually a very practical one, because this is something that we face every day with the lack of resources that we have in our governmental hospitals.
May I comment, please, on the presentation?
Sure, of course.
Thank you, Dr. Sommer. Very interesting, and it's a very important topic. Thank you, Dr. Asma or Dr. Shireen, for supervision. I want to stress that it's really very important to put the clips before the first cycle of chemotherapy, because sometimes, not sometimes, a lot of times, the tumor can completely disappear after just one cycle of chemotherapy. It doesn't disappear after several cycles, and then the patient is said to us too late, we can't see anything, and it's a problem. So we need to stress that clip is inserted before the first cycle of the chemotherapy. And another thing I want to speak about is that the clip after complete resolution of the tumor is a huge problem sometimes for us on ultrasound, and we cannot detect it at all because it looks like the fibrous septa. So we have to go to stereotactic. The only option for us to put a wire after treatment is a stereotactic guidance, because we can't see it. And recently I've read that abroad they're using something called a hydroclip. A hydroclip is a clip surrounded with some fluid, so even if the tumor is completely treated with chemotherapy and we can't see anything, we can see the clip inside of the fluid, and we can mark the site of the tumor bed. Thank you very much. It was very...
Thank you, Dr. Sommer. We have a question from the panel, and then we will move to any questions from the floor.